Welcome back, everyone. Thank you for joining us. The Med Safety Exchange webinar series by the Institute for Safe Medication Practices Canada, ISMP Canada, with support from the Canadian Medication Incident Reporting and Prevention System, CMIRP. As always, this webinar will be recorded and the link to the recording will be posted on the Med Safety Exchange website about a week later, along with any resources shared by the presenters. We have all the lines muted, and although we will not be able to have the usual discussion period at the end, we'd like the chat box to become a discussion forum throughout the webinar. So the chat box icon is below the slides on your WebEx screen. You'll then have to expand the chat box on the right panel, and then click on To All Participants before typing a question or comment. By doing this, your name will be attached to your comment, so if you would like to remain anonymous while participating in the discussion forum, you can instead do To Host, which is ISMP webinars, and then our host will copy your comment without your name and put it into the chat box. Although we will read every comment and question in the chat box, we may not be able to answer or address them all in the discussion forum during the webinar. So we do encourage all presenters and participants to join the discussion in the chat box because all of those comments and questions will be used to help prioritize and inform our current and future pandemic work. The purpose of this webinar series is to encourage reporting, sharing, and learning of med incidents and med safety topics. And today's webinar is specifically focused on the pandemic's impact on care in multiple care settings. This webinar will be a series of short presentations from direct care practitioners in hospital and long-term care and national health organizations such as Patients for Patient Safety Canada, Health Canada, the Canadian Institute for Health Information, the Canadian Patient Safety Institute, and ISMP Canada. I'd like to welcome our first speaker to describe select changes in hospital pharmacy practice as a result of the pandemic.
Hello, everybody. I'd first like to thank ISMP for this opportunity to share the experiences and challenges facing hospital pharmacists and pharmacy staff during this COVID situation. Next slide. From the hospital perspective, I think the areas that we'll focus on is how hospital pharmacy practice had to adapt to sustain business continuity, understand why we had the drug shortages and conservation strategies, consider the impacts to specific management protocols during this pandemic, specifically treatment of COVID-19 as well as palliative care, and then also look at strategies to ensure optimizing medication management during this time. Next slide. At the beginning, again, like many of us, there was a significant amount of information overload. At that stage, it was so important to ensure that there was collaboration and communication from leadership as well as down to the front line. At that stage, I think all hospitals essentially put in an IMS structure or an emergency operations center to ensure that there was collaboration of multi-stakeholders and communication to ensure that policies and practices were put in place to manage the COVID situation. Considerations included increasing ICU beds, opening field hospitals, decreasing exposure to patient risks, as well as conservation of PPE, and as well as the mental health of healthcare professionals. From a pharmacist perspective, the focus really in terms of patient care and patient discharges were supports that needed to be put in place to support virtual care models, whereby in some sites, physicians might not physically be on site to sign prescriptions, to look at legal responsibilities of ensuring that signatures were acquired or authenticated to ensure that patients were able to receive their discharge prescriptions in the community. Considerations for pharmacy staff also included PPE, This in particular was specific PPE to support compounding of hazardous cytotoxic based on the NAPRA standards, as well as determining a list of essential medications that would be required to support treating COVID patients, as well as sustaining some of our chronic patients and management in the hospital. In terms of operational effectiveness, the pharmacy had to look at how best to put together code blue kits, rapid intubation kits, and then also looked at managing and extending hours of operation, whereby hospital pharmacies essentially had to create tiers or teams to support 24/7 services in the hospital context. Next slide. From a drug shortages, the reason why we encountered this situation was right off the bat, hospital pharmacists identified that many of the patients that were vented required 2 to 3 times more medication than our typical acute respiratory distress patients. In that, we noticed that conservation measures definitely needed to be put in place, and different strategies had to be considered to manage the drug shortages, looking specifically at different pack sizes, concentrations, alternative therapies that could be managed for the same indication. And in addition to that, some of the risk that we encountered was the Health Canada interim order that was enacted to actually allow drug products to be brought in and pre-approved from other countries, such as the US, from Spanish, as well as the UK. With that, there needed to be consideration with respect to different concentrations, labeling, such as look-alike and sound-alike medications, similar to the recent MDI that was brought in that is actually labeled UK Salamol, but what is exactly, but the active ingredient is actually salbutamol inhalers. In addition to that, there needed to be considerations with respect to storage, whether the product was latex-free. There was also incidences where products were actually brought into the hospital that was short dating. And in addition to that, hospital pharmacies had to consider whether or not they needed to break down those pack sizes into smaller doses, so in order to conserve the supply. So with that, there was review that was needed in terms of looking at stability and sterility of the product, as well as considerations for programming the drug library to support the infusion pumps, health information systems, mitigating selection error as well. Next slide. In addition to that, there was significant considerations with respect to the impacts to management protocols. More specifically, to manage COVID-19 patients, looking at supply of sedatives and neuromuscular blockers that were in short supply, ensuring that there were alternative protocols, recognizing that one neuromuscular blocker might actually not sustain all patients, so there was multiple protocols that needed to be put in place to support the shortage. In addition to treatment therapies that were looked at with respect to treating COVID, such as hydroxychloroquine and remdesivir. The challenges with those products was that they were being used off-label, as well as facilitating special access supply, as remdesivir was not available and marketed in Canada. Reviewing clinical trials to ensure that the quality of the evidence, and also looking at the potential risk that patients were facing with COVID. In addition to that, to support decreasing staff from being exposed to droplet procedures, there needed to be protocols in place to convert nebules to MDIs to support patients. In addition, the other protocol I think that really was heightened was supporting palliative care symptom management. And due to the drug shortages, further review and protocols needed to be developed to support alternative therapies, recognizing that there was an overlap of the drugs that were used to manage COVID ventilated patients as well as to support palliative care patients. Next slide. So the other last component that we really pharmacists had to address was strategies to continue to optimize medication management. And I won't get too much into this, as I know there will be further discussion from the next speaker. But the strategies really were to decrease exposure for specifically other healthcare professionals like nurses, as well as ensure conservation of PPE and balance the workloads of some of the nursing staff, as again, there were some challenges with maintaining capacity of resources at this time. Next slide.
Great, thank you so much for sharing that. So many considerations in the hospital setting. That's a great segue into our next speaker, who will be discussing medication management for the complex patients in a long-term care setting.
Hi, thanks so much for the opportunity to share my experience of managing patient care during this pandemic. In long-term care, COVID has definitely exacerbated the challenge of understaffing and infection control. And one of the solutions was to aid with medication compression. So reduce medication administration times from 4 times a day to 2 times a day, which means there's less nurse interaction, which means there's less risk of transmission. And of course, there's less staff required to administer the medication safely. We learned really quickly that everybody needs to be involved with medication compression. And that everybody needs to be involved. So that means home management, prescribers, pharmacists, nursing staff, because when it's done in an insular manner, you don't account for all the aspects of implementation. So just to kind of give an example is that at one home, we received 1,000 medication order compression changes in one day, and there was not enough for staff in the nursing home to process staff in the pharmacy to actually implement those changes. So then looking at the next aspect, which is consent, this is actually really important in long-term care. There's a lot of panic and anxiety around COVID, and you need to reassure the family members that we're not abandoning their loved ones. We are doing our best to take care of them, and you need to have that substitute decision maker buy-in. Otherwise, that medication compression is moot, all that work. The next team is having like your prescribing team. You want the prescriber, the pharmacist, and the nurse all involved with medication compression, because that's going to make sure that all patient goals of care are kept in mind, that we're not going to have communication back and forth multiple times. You're going to catch drug interactions right away. And also you can incorporate any sort of resident response. So the nurse can tell you whether a resident will respond appropriately to a medication change or not. After we fully determined that every single person needs to be involved, we needed to discuss, are we going to implement these changes immediately or only if an outbreak occurs? Well, looking at medication compression, the main purpose was to reduce risk of transmission, so it made sense to do it absolutely immediately. It's also a labor and time intensive process, and you do not want to be dedicating those resources when you have an outbreak in the home, when you're focused on symptom management and isolation. The next question that we had with medication compression was, will these changes have to be reversed? Do we go back to how things were, if at all? This is mainly important only when you're putting medications on hold. And most of our homes decided that they were not going to put a lot of medications on hold because we couldn't determine how long this pandemic was going to go on for. Was it 4 months? Was it 18 months? And would there be any unintended consequences of holding medications for that length of time? Would we also forget to restart medications a year and a half from now? And also the guidelines, suggestions, and recommendations have been changing so rapidly with COVID that maybe holding medications right now, we need to be restarting them shortly after. An example of that is, say, like vitamin D. So after we determine we need everybody involved, we're going to do it right away, we're not going to be making any changes later. The process that we came up with was that the pharmacist was going to reach out to the home management and medical director to determine implementation dates, ensure all of us were on the same page with regards to holds, pastimes, consents, and that all prescribers were aware going forward that all future orders would be BID rather than QID, sorry, twice a day versus 4 times a day. That we would set a time for rounds where the prescriber, nurse, and pharmacist would be available, that we'd all be working off the same documents, whether it was online or paper, and making sure we had the right amount of time set aside. So on average, it takes about an hour to do medication compression for about 30 residents. We also found out that having the pharmacist transcribe the orders resulted in less need for clarifications. They were able to specify, how the orders were going to be changing. So say we were changing levothyroxine, vitamin D, and furosemide from 0800 to 1200, we could say that specifically, rather than having a blanket statement of changing all 0800 meds to 1200. Also specifying that when a medication was going to be reduced, having that very specifically in the order of reduce acetaminophen from 4 times a day to twice daily. Communication is so important during this time, so we had to make sure that the orders were going to be communicated either via PDF or fax, because all these rounds were taking place virtually, over the phone. We also wanted to make sure that it was communicated clearly when the consents were going to be obtained. We didn't want them to happen after the changes were made by pharmacy, because then that meant we were going to have changes back and forth, and we were going to have an increased risk of errors. We also wanted to make sure that communication would happen with the nursing staff as to when the changes would be reflected. Our medication compression rounds could happen on Monday, but the changes would not be reflected on Wednesday. So making sure everybody's all on board at the same time. Lastly, having a clear and concise way to communicate any discrepancies that come about during medication compression to make sure that errors are corrected as soon as possible. So just kind of like the last words is that, collaboration, communication is so important. And if COVID has taught us really anything, is that we need to come together in order to be successful.
Excellent. Thank you so much for sharing those detailed insights with us. I'd now like to ask our third speaker to describe her experience and feedback on virtual care in the community.
Thank you. Good afternoon, and thank you to ISMP for including a patient perspective. The focus for patient safety is on patient safety, and my particular focus is on medication safety and the role of patients and public education to help improve patient safety. So from that lens, for today's discussion, we took a small survey of patients who have had virtual medical appointments during these first weeks of COVID-19. This isn't a scientific survey, and I understand that many jurisdictions are conducting robust surveys at this time. But for now, I'll speak of the information we were able to gather asking patients across Canada about their recent virtual medical appointments. Next slide, please. We asked 6 questions, so let's go over them and the results. Number 1, with 10 being top marks, how would you rate your experience? The satisfaction rating was exceedingly high. There was only 1 failing grade, and the overall experience from participants was a solid 9 out of 10. For question 2, without an office visit, were you able to get the advice and treatment you needed? Almost all respondents said they were able to get the advice they needed. Some indicated that test results were reviewed, and one participant noted that a phone appointment was not as beneficial as a video appointment would have been. Number 3, if available, would you like the option to continue with such visits after COVID restrictions are lifted? Again, all but one respondent indicated that they would like to have some virtual appointments in future. Number 4, was your appointment via phone or online? If online, what platform did you use? Most participants, over 70%, had phone appointments only. One participant talked about an email back and forth discussion that was satisfactory, and the remainder had video appointments, and those who identified the form they used Zoom. One participant indicated that follow-up instructions were sent via email. The 5th question was, would you recommend this to others? All but one of those surveyed indicated they would recommend virtual appointments to others. And number 6, do you have any suggestions to improve this service? Next slide, please. We had a lot of information coming in on suggestions and comments to this, and we were able to break it down into 4 main themes. The opportunity to change and improve the healthcare delivery, the appreciation of reduced travel, especially for those in rural settings and those who commute. Many indicated appreciation of time savings and reduced exposure to other illnesses, and many suggested that information on preparing for virtual visits would be helpful. Next slide, please. So to that suggestion, I would point out two current public education tools. Both have been created by ISMP. So the internationally used 5 questions to ask about your medication tool frames discussions about medication. It helps in the knowledge transfer between provider and patient and specifically addresses the importance of patients noting all medications they're taking, including those over-the-counter and natural health products that are sometimes omitted. Next slide, please. ISMP's second public education tool is a recently published consumer newsletter on how to prepare for a virtual meeting. This information assists patients prepare for a successful appointment and could be emailed to patients before their first virtual meeting to help make the most of the appointment. I do look forward to hearing results of the large provincial and national studies, but from this small sampling, it would suggest that there may be an opportunity to continue virtual appointments post-COVID. And finally, on a personal level, I want to thank all of you, our healthcare providers. Thank you for what you're doing during this time.
Great. Thank you so much for providing us with an invaluable patient and consumer perspective on care changes, particularly how that might continue post-pandemic. I'd like to welcome our fourth speaker from the Patient Safety section of Health Canada to describe their work during the pandemic.
To thank those of you, especially pharmacists who presented initially, for all your hard work during this pandemic. We really appreciate it. And just following up on what we heard earlier about the drug shortages, I'd like to highlight some of the work that the Patient Safety section Health Canada has been doing to try to help manage the drug shortage challenges, and in particular to ensure that any products that are being brought in from other sources are ensuring a safe supply. As many of you probably know, in late March, the Minister of Health signed an interim order to allow certain drugs that may not fully meet regulatory requirements to be imported and sold in Canada. So this is just a quick mechanism to allow us to bring in supply to address acute shortages. So they created a list of drugs that could be considered for importation, and so this is called an exceptional drug shortage list. And for a drug to be designated for importation, it had to meet the following criteria. So first of all, it had to be in a significant shortage, which really means that there was a low availability of alternative supplies or therapies, and that the company that was proposing to import and sell the drug from another source in Canada had to have assurances of high quality and good manufacturing practices. So how did this work, and how did patient safety get involved? So for a foreign product, so a product that had been approved by another regulator, for this product to be considered for importation, the company first submitted a proposal to Health Canada, and in that proposal they were articulating how they would communicate any issues about that particular product, so what we called a risk communication plan. This proposal was reviewed by 2 groups. First, the pre-market area, so that they could compare it to any equivalent product in Canada and confirm the quality and the content and make sure that the information about the product was consistent with what we had in Canada. And secondly, it came to the patient safety group. This is a group that's in the post-market area of Health Canada. And the patient safety group looked at whether or not the introduction of this foreign product into the Canadian market could introduce a risk of medication error that could result in significant patient harm. The group also looked at the labeling and packaging of the foreign product to see if it could, if it was clear for healthcare professionals to use. In some cases, when it's a UK or a US product, the information is in English, but in other cases, it could be from other countries where the language may be more difficult to understand. And the patient safety group also considered whether or not the communication pieces that were being proposed by the company was sufficient, or if there was need for a targeted health product risk communication to mitigate any risk of medication errors. So some of the examples of the drugs that ended up on the designated list, and this is in the public domain, some of you are probably quite familiar and it was alluded to before, are propofol, some of the neuromuscular blocking drugs like rocuronium, morphine, hydromorphone, fentanyl, meropenem, midazolam, and salbutamol. This is just a few of them, but the list is posted online, and I could perhaps provide the links in the chat later on. Some of the examples of risks that patient safety had identified that we felt really needed some mitigation were some of the foreign products had different concentrations. They may be in a different dosage form. Perhaps the expression of strength was different from how it's labeled in Canada. One common one we saw was, micrograms or micrograms using the Greek letter. In some cases, the packaging safety features were perhaps missing from the foreign product as compared to the Canadian product. And we've already communicated on this, and common one was the neuromuscular blocking drugs. In Canada, the standard is to have a red ferrule with a warning statement on it. Some of the foreign neuromuscular blocking products being considered for importation were missing that particular feature. And as I mentioned before, some of the labels were not even in English, so it made it quite challenging to know what the product was. And some of them had different instructions for use. Good case in point, and we've communicated on this, is salbutamol. Sometimes the priming instructions were different for a foreign product versus what we might see in Canada. So in normal times, our group would make recommendations to improve the labeling of products to really support their safe use. But in the case of COVID and the importation of these foreign label products, we didn't have that capacity. We didn't have the luxury of time, because once the company submits a proposal and they get approved, they can import fairly quickly. So we have to make sure all the concerns are addressed right at the top. And in terms of what we could do, we were really quite limited, and really the only tool we had currently was really to look at some type of communication. So in some cases, the company proposed a customer letter that would be sent, as you often see, to wholesalers or to your purchasing groups, and it would provide a comparison of the foreign product label versus the Canadian, highlighting similarities and differences. In some cases, they were proposing to provide an English package insert, so we felt that was definitely needed for those where the information was not available in English or in French. And in some cases where we felt that there could be a heightened risk of medication errors, we could propose to the company that in addition to all of this information, they would have to issue a targeted risk communication to hospitals so that the hospitals can disseminate to the frontline workers. And so, as I mentioned, there are two areas where you can see what drugs have been accepted. So there's what we call a list of drugs for exceptional importation and for sale. And as a foreign product gets approved for importation into Canada, it gets added to that list. It's a chronological list by date, so it can be a little bit difficult to see, what are my alternatives for a particular component. But there's also a list of drug shortages, and that's more alphabetical, so you can go there to see what type of products will be allowed, and then go back to the list of drugs for exceptional importation and see which formats have been approved. just yesterday, Health Canada communicated on two particular foreign products. One was a Spanish label salbutamol, and the other one was a foreign product for propofol. The foreign product is twice the concentration of propofol that is currently available in Canada. So that one really concerned us quite a bit, and so the communication is trying to heighten the awareness about that difference. And so that's what we want to share with you today, and thank you very much for your time.
Thank you so much. It was so great to hear about all of those safety considerations and communications, really trying to mitigate errors from drug shortages. I'd now like to ask our fifth speaker to share with us the lessons learned as they support stakeholders during the pandemic.
Thank you. My name is Melanie. I'm from the Canadian Institute for Health Information. So this is going to be a slightly different presentation from the other ones that you've heard about today, because our work has really focused on supporting the macro level lens of what's going on in our health systems during the pandemic. So some of you probably already know CIHI, the Canadian Institute for Health Information. Essentially, we work with the provinces and territories to collect and report on data about the healthcare system. We receive data from hospitals, regional health authorities, long-term care facilities, and governments. Most of the information that we receive from these partners is on a quarterly or annual basis, so that we can create comparable and actionable data that's available at different levels within the system. As you probably suspect, during this COVID time, quarterly or annual data is not sufficient for our information needs. So given our role in publishing information about the healthcare system, we received lots of questions early on in the pandemic, and this has been going on now for several weeks. So these questions have come from our partners at a policy level, so at the federal government, from Health Canada, the Public Health Agency of Canada, as well as within the provinces and territories from the Ministries of Health, as well as some of the ministries responsible for the economy. We also worked quite a bit with health system leaders, so hospital leaders, long-term care leaders, as well as the media. I wanted to share with you just a highlight of how these questions and these information gaps have evolved over the few weeks of the pandemic. So at the very beginning, you'll probably remember kind of the media as well as your own organization really trying to just get a handle on the situation. So how many cases of COVID-19 were there in the country? Where were these cases? How many people were being hospitalized? So there was that very basic information that was missing, and everybody knew that we needed to pay attention. We'd seen the international examples, and we were trying to assess how to make that local information available. Soon thereafter, we started talking about preparedness of our healthcare systems, and in particular of our hospitals. So based on the European situation as well as the Asian situation, we knew that we needed to make sure that we had space in our ICUs and that we had the proper ventilation equipment. But questions like how many beds are there within the system, how many beds are available for ICU, how many ventilators do you have as a country, is actually a very hard question to answer, depending on how you count and what you count, and especially as a situation was quickly evolving. So we knew that many health systems, provinces and territories, and even as a country, we were looking to acquire new equipment such as ventilators, but we were also creating capacity within our hospitals that would be quote unquote non-traditional beds. So for example, we knew of some hospitals that were partnering with local schools or with local hotels to provide space if that became available. From a capacity management point of view, in the past, I would say month to 6 weeks, the focus has really been on monitoring that surge capacity within our hospitals. So do we have enough space to handle the demand? And so one of the roles that we have played along with the Public Health Agency and Health Canada is creating a daily report for our senior officials that collects information on the daily use of hospital beds, including how many COVID patients are in the hospital, how many are in ICU, the average length of stay in ICUs, for example, so that we could get a handle on whether any of our systems across the country were becoming overwhelmed and might need additional supports, or where we might need additional PPE or ventilators. So thankfully, that has not materialized yet within any of our systems, but it is something that we monitor now on a daily basis. And for CIHI, this has been a very different type of response for us, given that it's a daily data collection that we do with the provinces and territories. And it's one that involves essentially a decision tree and a calling tree where our local client affairs managers are reaching out to different partners across the system, and we're collating information manually to make that available. In the last few weeks, I would say we're talking more or receiving more questions around what I'm calling the system strains. So what is happening with our workforce? What is happening in our long-term care homes? And what are the costs that are being associated with this COVID pandemic and the displacement of care that has happened? And just recently, you'll have seen in most of your settings kind of the considerations for reopening our hospitals, especially around elective surgical capacities and ALCs, and reopening patient flows between the different sectors of the healthcare system. So one of the other pieces of work that CIHI has done over the past few weeks has been to establish some new services. So one of the things that we did very quickly was look at how we might support the provinces and territories, and in particular those with less capacity, to do some of the modeling that would be required to understand the capacity of their systems and whether or not they needed additional supports. So we set up a modeling unit within CIHI because we had a skilled workforce and we had lots of data from the past that we could draw on to help predict the future. So we worked very closely with the provinces to develop some of those modelings, or to advise on the different models that were being developed across the country. And one of the roles that we played there was around a best practice exchange, where we brought together different modelers from different provinces so that we could share our assumptions and our data sources to make sure that we were creating the best possible picture as the situation evolved very quickly. Our modeling also focused on identifying some of the vulnerable populations, both within our communities and in our long-term care homes. So especially in the long-term care sector, we know from the very beginning that most of our patients are vulnerable, but some of them are particularly much more vulnerable to respiratory illnesses. So we developed models to be able to identify those populations. On the drug side, we are monitoring medication incident reports to see what we can share to assist with the work of ISNP Canada and our data partners. We haven't seen anything specific to COVID-19 in NSER to date, but we know from other sources that there are issues related to the use of IV tubing extensions, for example, and ISNP Canada has released a bulletin with some guidance on this practice. So this is something that we'll be monitoring as the data continues to come into us. So as a reminder, it is very important that these incidents be reported and shared and learned from broadly. So we thank you for continuing to report those. And if you would like more information about NSER, I'd be very happy to take questions or to put you in touch with our team. On the drug side of things, we continue to monitor the impact of the pandemic and of the policy changes that we've put in place on the use of drugs in the community. We don't have any hospital drug use, but from a community perspective, we are looking at the impacts of limiting prescription size overall drug use patterns, as well as monitoring some of the drugs more closely where we expect or have heard of impacts on the use or the supply. So examples have already been mentioned here today, but they include things like hydroxychloroquine that you see on the news and on Twitter almost daily, as well as salbutamol, where there have been reports of limited supply. In terms of CIHI's work going forward, one of the pieces of information that we will be doing, or pieces of analyses that we will be doing, is looking at the impacts that COVID has had on our healthcare system for this first wave, with the idea of identifying some lessons learned if there is to be a second wave of a pandemic, or just for system learning and sustainability in the long term. A few of the topics that we are interested in exploring include the rates of hospital harms. So we know, for example, from the H1N1 pandemic that there was a quote unquote halo effect that happened after that pandemic, where the protocols that were put in place in the hospitals, particularly around sanitation and hand washing, had a protective effect on infection rates over time. That lasted between 8 months and 2 years in different settings. So what are we seeing on the harm side of the system? We're also interested in the secondary impacts. So for example, clients with cardiac issues or other clients who may have needed dialyses. What was the consequences of displacing elective surgeries? What were the consequences for mental health care, for example? So those secondary impacts, I think, are starting to be felt across the system, and it's something that we will be unpacking once we receive more of the data from our partners. And obviously, we are looking at the consequences of that displaced care, and in particular, the elective surgeries, so that we can look at how different hospitals or different regions are scaling up and scaling down that capacity in order to meet both the demand on the surgical side as well as any potential demand from the pandemic. So like the other presenters, I want to thank you all for your continued work, whether you're at the front line or in a back room. I think the work that we're doing is extremely important. We know that disruptions are risky for patients, and this is a particularly disruptive period. So thank you very much for your work.
Excellent. Thank you so much for sharing that more system perspective. And I think we're all looking forward to hearing more about some of the impacts that you guys discover in your work. Our sixth speaker will now describe some pandemic-related work to support patient safety.
Thanks, Ambika, and hello, everyone. Thank you for joining us today. Before I get into it, I just want to give a brief overview of CPSI's approach to the ongoing pandemic response. We remain committed to our health system partnerships and to collaborate for collective impact where possible while this is going on, and we're focusing on avoiding duplication and ensuring that we aren't adding any unnecessary burden, strain, or distraction to our health systems managing the crisis. Our priorities in patient safety remain the same, yet we're focusing on being agile and receptive to our stakeholder needs and also to emerging priorities from the ongoing COVID-19 response. A few tools and resources that we believe are relevant right now. One is the Psychological Safety of Healthcare Workers Peer-to-Peer Support Toolkit that's now available on our website. The toolkit and manuscript outlines best practice guidelines, tools, and resources that policymakers, accreditation bodies, regulators, and healthcare leaders can use to assess and help support the needs of healthcare workers as this crisis continues. A second tool is our Canadian Guide on Engaging Patients and Patient Safety. We believe never has it been more important with so many changes in the way that care is being delivered right now, that we should be engaging patients and making sure our patients and public are empowered to make decisions about their health and make sure they are safe throughout the crisis. Our annual Stop Clean Your Hands Day campaign commenced this year on May the 5th. It was one of our most successful and popular campaigns to date. There's plenty of resources, self-assessments, fact sheets available for you to use on our website, and that links up with a lot of the work that the World Health Organization has been doing as well. And finally, our Global Patient Safety Alerts tool. We've added a new COVID-19 category that's going to be populated with alerts, advisories, and recommendations from our contributing organizations as they come in. We're working on connecting with those contributors, and those alerts will be prioritized on the website as well. A few emerging topics that we're currently working on, naturally with others in this group, is some of the Canadian and international incident reporting trends specific to COVID-19 treatment. For example, unusual working conditions and increased risk or potential for harmful drug interactions. Another topic is we're looking at policy and regulatory gaps and challenges that the pandemic has exposed. For example, some data transparency between health systems to allow for a timelier response to patient safety risks in Canada, but also internationally as well. And then the third is the impact on patients at transition points and in the community. So please visit our website for the latest on what's going on for us in our work. And don't hesitate to connect with us. We'd be happy to connect with everyone in the health system to understand what your needs are as we collectively manage this pandemic. So thank you, Ambika, and back to you.
Great, thank you so much, Steve. So many great learning tools that were shared. So hopefully you can participants can go to your website and get those tools for themselves. And last but not least, our seventh speaker will describe some of ICP Canada's work to support medication safety and mitigate errors during the pandemic.
Thank you, Ambika. It's Mike Hamilton from ICP Canada. It's a pleasure to be amongst all the speakers and the participants today. As you've heard from them, there's really a lot of work happening in all areas of healthcare, and certainly a lot of behind-the-scenes work that goes on to provide safe healthcare in these unsettled times, from the macro sort of lens of CAI all the way down to bedside care. And there's even some evaluative work going on, both from CAI and from Patients for Patient Safety Canada, that I've found fascinating. Next slide, Ambika. At ICP Canada, our projects are proceeding as much as possible, and our main focus is still on providing support to our stakeholders, in particular frontline workers. We don't deliver healthcare as an organization, but we are hard at work with our collaborators, stakeholders, and like everybody, we're working together to solve problems, to sort out the best way of ensuring the safest care possible despite the circumstances. And furthermore, we're making sure people hear about it. We're working hard to develop guidance to medication safety issues we haven't seen before, like sanitizer in beverage containers and a lot more care being provided remotely. And we're expanding on the guidance that we have seen before, such as virtual medication reconciliation, making verbal and telephone communication as safe as possible. And we're doing our best to answer your medication safety questions and fielding questions from clinical workers, from administrators, from regulatory colleges. We may not have all the answers, but we are collaborating with everybody to determine the most reasonable courses of action and to learn from those initiatives. And we're also working with our stakeholders to ensure everyone is aware of the current concerns and any potential mitigating strategies. Next slide. At ICP Canada, our analysis teams are exploring issues such as drug conservation, drug hoarding, and the effect of limiting dispensed amounts, and how this can lead to certain types of drug shortages and how to deal with those effects along with our partners. And how some of these drug shortages lead to working with new products, as you've heard, in unfamiliar appearances, or substitute products in different formulations, and even familiar products in totally unfamiliar packaging, or imported products in foreign languages. And we're trying to understand what novel risks there exist about providing medication therapies in isolation or in distancing situations things like extra long IV tubing or using pumps that are quite far away from either practitioners or the patient. And of course, we're seeing the hand sanitizer in water bottles, in wine bottles, in vodka and gin bottles, and trying to understand how best to deal with that. We're dealing with communication issues between practitioners using verbal and telephone and text and remote orders, and between practitioners and patients, as you've heard. And recognizing problems with how do you do good medication counseling remotely, and how do you ensure that patients and caregivers understand how to take their medicines. And we're also trying to understand why patients are perhaps foregoing care or not taking their medications and what to do about it. We're also seeing concerns about clinicians working in unfamiliar roles and what the implications are of that. And in response, we've been producing both practitioner and consumer-related bulletins at remarkable speed, and we're thankful for our writing and editorial crew and to our peer reviewers for their availability and willingness to turn around things on a tight timeline. So please check out the bulletins on our bulletin pages and use them to help answer any questions and concerns you have about medication safety. Next slide, Ambika. All of these issues we've learned through our reporting mechanisms, and we have learned about your experiences through our online systems, our online email, and by phone calls. And this is what you and your colleagues have been challenged with. And we've noticed during the pandemic a decrease in incident reporting, and this is entirely understandable given the circumstances. And I think other reporting systems and other organizations have experienced this as well. And we appreciate that right now there's other priorities, but please continue to submit reports pertinent to the pandemic. We know that there's unique, complex, and unusual incidents and concerns that arise from trying to deliver care during these circumstances. So please help us and help others by continuing to report these challenges. Next slide, Ambika. Thank you, everyone. Thank you for tuning into this episode of Med Safety Exchange, and thank you for contributing so much to the discussion. Thanks to those who contributed to the chat box. We won't be able to respond to all of the questions and comments, but we do promise to read them all. A wholehearted cheer as well to our presenters today for sharing their experience and their contributions to everyone's ongoing work. Next slide, please. Recording of the webinar, as well as any shared resources, will be posted on our website in about a week or so, so please be sure and visit. Med Safety Exchange will now take a summer hiatus. However, we'll be back in the fall, so keep your eyes open for an email update in later summer. Next slide, please. On behalf of ISMP Canada and the Med Safety Exchange, thank you to all so much for participating, and thank you for contributing. And please remember to fill out the poll that's available now. Until next time, take care.